Okay, so what do we decide on treatment? Bev, no Bev?
I think we decided every 3 weeks because I'm in charge. So every 3 weeks.
Exactly.
Like usual.
And no Bev.
Okay, so every 3 week Taxol.
Yeah.
Paclitaxel with carboplatin and no Bev. Okay.
Reasonable.
Okay. All right. So if you go to the NCCN guidelines, no matter what answer it was, I think every answer, even if one you come up with, be right on target. You said it. You said Taxol. I heard it. Good. Okay, so they're all candidates. So now what?
So we're going to treat likely about 6 cycles, typically reassess, make sure we've gotten what we wanted, meaning there's no evidence of new disease. And
so you're going to do 6 cycles and then re-image, or just do CA-125? Do you re-image after 6 cycles of chemotherapy?
I do. Many of my partners do not.
Right.
I think it's a nice baseline.
Yeah,
as Susanna said, you have a group of patients that are going to have lymphocysts in the future, may be misinterpreted as disease.
Okay. And then what?
And then, so prior to all this treatment, I've already been counseling her. This is, again, a known BRCA patient.
Right.
And so we've been talking about that this is not going to be the end of therapy.
Right.
So at the completion of chemotherapy, give her a few weeks off, and then, typically within about 3 to 4 weeks, start on olaparib.
Okay. Okay. And what's your kind of standard approach to that? Like that first cycle, what do you do? Do you do anything differently, or?
Well, I mean, I think a lot of this is counseling, right? So first, of course, the goal is for the patient to live longer without disease, and but you don't want to be adding additional toxicity. This is a population that before this was surveillance. They were on nothing and they were feeling good, and they were off treatment, and this is their window. This is kind of their honeymoon time. So you want to make sure that you make it as much of a honeymoon as possible, and so really counseling these patients and making sure they know that even though this isn't chemotherapy, that there are side effects, but they're manageable. And so we generally see our patients once a month when they're on olaparib maintenance, but we do, make sure they have ample access to the clinic team so that if they start to have nausea or any symptoms that make us concerned, that we can intervene before that 1 month time point, because you don't want someone to be struggling through that first month, with fatigue and nausea and things like that, and then just be done with treatment.
And we know that treatment modifications are frequent with these drugs. Right?
So that's part of our counseling, is that around 1/2 of patients will require a dose reduction, and they all go home with antiemetics, and we follow up with them within the first week with a telephone call, but then see them monthly. But part of that education is right from the beginning of manageable, but the manageable often includes dose reduction and antiemetics or other medications for fatigue.
We often send people home with a prophylactic antiemetic. Don't necessarily tell them they have to take it, but kind of counsel them just like you did with chemotherapy. If you find that you're starting to have nausea, then go ahead and take that 30 minutes to an hour before you take your drug, and see if that doesn't get you where you need to be.
So I cheat a little bit. I actually do it the reverse. Okay, so I actually start at let's pick a PARP inhibitor like olaparib. I start at an intermediate dose, so like a 200 twice a day, and then I give it for a week. I give it for a week and a half, and I acclimate the dose to 300, which has actually saved me a lot of dose reductions over the course of time. I know that's not how you're supposed to do it, but that's how we do it.
No, actually, in practicality, we were doing that as well.
Exactly.
Yes, absolutely.
And the dosing and the availability to escalate or de-escalate is sometimes easier at those doses.
Right.